As you can see, it's really hard to see all the boundaries in this X-ray, and everything looks like this could be just a pneumothorax. Hello, welcome to Tala Talks NICU. I'm Dr. Tala and I'm super proud of the fact that I figured out how to record from my computer screen. So today we're going to go over how to read X-rays. There'll be plenty of videos on abnormal X-rays after this initial one, but here I'm going to go over the basics of just how to read X-rays. So let's start with this. When do we actually get an X-ray in the unit or in babies generally? Well, as this slide lists, there's lots of different reasons we get X-rays. Remember, this is a brand new patient in the world, and however good the OBs have gotten at identifying stuff that's gone wrong prenatally, we can always be surprised. So we should have a pretty low threshold to get that initial chest X-ray. So really a baby with any abnormal respiratory symptoms, breathing at 120 times a minute or grunting or a lot of flaring or whatever, after that kind of initial transition period, really any oxygen requirement, you might assume that it might be like a bit of mild TTN or something, but it really could be an undiagnosed CDH. Also, you might get an X-ray to evaluate a cardiac silhouette, maybe to look at esophageal abnormalities. You might be wanting to check line placement, whether it's a UVC, a UAC, a PICC line or whatever. You might want to look at bony abnormalities or really anything weird that might be going on with a baby. But also remember that ionizing radiation is a known carcinogen, and that the greater the number of X-rays an infant receives, then the greater the cumulative exposure to radiation. So think about that before you just get the 8th chest X-ray, just making sure that the lines are perfect, or let's just see how we're doing X-ray, or it's Wednesday, so let's get an X-ray. Also realize that the younger the patient, the greater that the X-ray risks. So obviously our micropreemies are at risk for a double hit because we're worried about how much more growing they have to have done, and they're at risk of needing way more X-rays during their NICU stay. Obviously, the other side is many X-rays are life-saving, finding that pneumothorax or effusion or whatever, so we can't stop doing X-rays altogether. What we're aiming for is an ALARA practice, so as low as reasonably achievable. A meta-analysis was published in 2020 by Lee et al., which showed that the average radiation NICU infants received during their NICU stay. In the studies, they looked at ESD, or the entrant skin dose of radiation, which was measured in micrograys, and it showed that they had received between 12 and 110 micrograys during their admission. A gray is a unit of radiation. It represents an absorbed dose of radiation, and 1 gray is about 100 rads. So generally, the guidelines in the NICU, which are really very gray, on the pun, is less than 80 micrograys. The general guideline for pregnancy is that a radiation dose below 50 micrograys is considered safe and doesn't cause any harm. But just one more thing I want to add about radiation, and this is directed at everyone in the unit. Often these babies need to be held a certain way, and we often end up standing near the babies while the X-rays are being taken. All of this ionizing radiation adds up, so always stand at least 6 feet away, especially if you could be in your first trimester of pregnancy. So now let's talk about X-ray positioning. Nearly all of the time, the baby is supine, so lying on its back, and we're getting AP views. This is where the beam comes anteriorly through the baby and the plate is posteriorly. And most of the time, this is all we need. We don't need another view for TTN or RDS or MAS most of the time. We rarely get 2 views of X-rays unless there's something weird going on in the lungs and we can't figure out what it is or how big it is. So like a mass, or the diaphragm is abnormal, or there's a pneumothorax or a pleural effusion and you want to see how big it is. Another big reason for lateral X-rays is to look for line positioning. But you can see the lateral chest X-ray here, and that is where the infant is still lying on his back, obviously not an infant here, but the plate is now to the side of the baby and the beam also comes in from the side. And another slide that explains X-ray positioning. This is AP, so again, anterior-posterior, and then this is PA. We very rarely get this view since infants are nearly always on their backs. This is the lateral view, and then these are the decubitus views, which I feel like always really confuses people, where the infant is now placed on its side. We use these a lot more frequently to figure out what's going on in the belly. Often, we'll use the left lateral decubitus, which is where we have the left side down and the right side is up. If there is free air here, then it would trap under the liver and it would show a very clear black rim under the white liver. So that's really the most common time that we use that left lateral decubitus. And here we have two examples of AP and lateral x-rays. In fact, these ones we actually call babygrammes because they've basically captured a lot of the baby. Here, the lateral x-ray was helpful in checking the line positioning. Another thing I want to point out here is the number of artifacts that there are on this x-ray. Here you can see the probes and random lines above the baby. Here, luckily, they haven't really gotten in the way of being able to read the x-ray. But remember, if they do, you're going to have to repeat the x-ray, and that's much more radiation. So be really aware before the x-ray is taken how much stuff, so all of these like extra lines and probes and everything, are actually on the baby. Right, so let's get into actually looking at x-rays. And today we're just going to be looking at normal ones so that you have a really good fundamental basis for everything. So there are a few concepts I want to go over before we get down to reading the x-rays themselves. The first is that, like everything in medicine, the more you do something, the better you'll get at it. So get used to looking at every single x-ray your patient has. Often the x-ray pictures show up immediately on the machine, so look immediately. You know how busy units get, so never assume someone will see the x-ray immediately. The second thing is, look at the quality of the x-ray. Was the correct picture taken of the chest, not of the belly, for example? Was it definitely taken on the right patient? Has the x-ray been labeled appropriately? Are there loads of artifacts on the baby? And what's the exposure like? And we'll talk about that in a second. Also, is the x-ray itself rotated, which means the x-ray won't come out completely symmetrical. This is an example of a rotated x-ray. So usually when this happens, it's because the infant is kind of rolling over a little bit to one side. Sometimes it's okay, like in this picture, it doesn't really affect your interpretation of the x-ray, but other times it's really hard to figure out what's going on, whether the lungs are collapsed or whether there's a pneumothorax or something. The easiest way, I think, to check for rotation is just to compare the length of the ribs at the same level on both sides of the lungs. They should be equal in length. So this side should be equal in length to that side. If one side is shorter, and you can see here how much shorter this left side is than the right side, and remember, we look at x-rays as if we are looking at a person ahead of us. So this is the left and this is the right. And you can see that the ribs are much shorter on the left than they're on the right. So here we assume that it's rotated. As you all know, the heart is also on the left side, and the majority of the heart is on the left side in x-rays. But on this x-ray, it looks like the majority of it is on the right side. Again, also consistent with the fact that this is a rotated picture. In this case, you can't really say a lot about the heart border. Right, getting back to looking at the x-ray. As you all know, an x-ray is going to look black or white. The lungs hopefully are full of air and so will appear black because they don't provide a strong barrier to the x-ray beams, whereas bone or metal, for example, will appear white. I always say this to parents though, we want the lungs to be mostly black. If they're more whitish, then an x-ray is not going to be able to tell you whether that is fluid or blood or collapse, or maybe even another substance. And this explains it more scientifically. So the same level of radiation is hitting all the different surfaces. But the further the left the material is, the less that the radiation is absorbed and the more the x-rays are actually transmitted. So the more that it will reach the plate and the more black it will appear on the x-ray. So this is blacker or more radiolucent, like air. If the radiation is blocked, it will appear white, and this is more radio-opaque, like bone or metal. Fat is closer to air and will appear grey, and water will also appear grey but closer to white. This helps with being able to see the vessels easier. So, being able to differentiate between white and black is basically what makes us to be able to interpret an X-ray. If the X-ray is overexposed, then it will look really black like this one. As you can see, it's really hard to see all the boundaries in this X-ray, and everything looks like this could be just a pneumothorax. And this is an example of an X-ray which is underexposed, the one on the right. You can see how white the lungs suddenly look. So here again, it makes all the borders of the heart much harder to see. And sometimes when it's very underexposed, you literally can't see lines at all because they just blend into the bones. Obviously, the exposure of the X-ray completely depends on the radiology technician, so there isn't really a lot that you can do about this, but if you do notice that the X-ray is very hard to read because of the exposure, then it does need to be done again. Normally, a good way of looking at the exposure is looking at the gas bubble in the stomach if the X-ray has gone down low enough. This should be fairly black and roughly the color of the lungs. If there is a gas bubble and it appears completely white, then the X-ray is probably underexposed. You can't always look at the lungs and say, okay, if they're white, then they're underexposed because maybe the lungs are really sick. It's less likely that there is zero air throughout the intestines, so most of the time you can look at the gas bubble as kind of like your basis. All right, let's get to the meat of the lecture, why you're probably here, and how do we actually read X-rays? Obviously, we need to start by learning what normal chest X-rays look like. Well, there are many different methods people use to looking through chest X-rays, but one that's used a lot in training is the ABCDE method, and this is what each of the letters stand for. A for airways, B for breathing, C for cardiovascular, D for disability, and E for everything else. So let's go through this on an actual X-ray. So A, let's look at the airways. Let's look down the trachea. Is it midline? Can you see the carina, which is the point where the trachea branches off into the two bronchi? And then often you can actually follow the bronchial tree further out. B is for breathing, the lungs and the pleural spaces. As you all know, on X-rays, air is black and everything else is white. So you want to see some nice blackness of the lungs. You can count how many ribs expanded the lungs are. So 1, 2, 3, 4, 5, 6, 7, 8, 9. This is a well-expanded chest X-ray, well-expanded lungs. Generally, good expansion is 7 to 9 ribs on a baby. Obviously, you're not going to get a baby to hold their breath, and it's unlikely you're going to coordinate the breathing with the X-ray machine. So sometimes you just have to guess whether it's an inspiratory film, so breathing in and more likely to be more hyper-expanded, or breathing out and smaller amounts of lungs shown. Look for symmetry in the lungs on both sides and look for areas of increased whiteness. This could mean that there's extra fluid in there, or there's an infection or collapse, or really anything. Then look at the lung vessels. Can you see these branching out? Being able to see some blood vessels is good. When it's complete blackness, we're worried about not enough blood getting to the lungs, like with a pulmonary hypertension or hypoplastic right heart. So you can see these vessels kind of going all the way to the edges of the lungs like this. These kind of vascular markings are going all the way to the edges. Follow the margins of the lungs down to the costophrenic margins, which is where the diaphragms and the ribs meet. Is it sharp? Or is there a curve here, suggesting that there may be a fluid buildup? Then follow the diaphragms all the way to the vertebra on both sides. Are they symmetrical? Are they flattened, which could imply that the lungs are hyperinflated or the pressure that you're using is too high, pushing down on the lungs? C, cardiovascular. Here we're looking at the heart shape and vessels. In babies, the heart shape can be up to 50 to 55% diameter of the thorax. So here, if you take the length right there divided by the length of the total thorax, it could take up to 50 to 55%. So get used to estimating this. This often looks really big on babies. Also, as you know, most of the heart is on the left side. In fact, 2/3 of the heart is generally on the left and 1/3 is on the right. Like we said earlier, if the film is rotated, then this may appear differently. Then you also want to see, like we said, some hilar vessels and the vessels spreading out through the lungs. The presence of vasculature in the periphery is what would give you a clue about whether there is lung there or whether the baby popped a pneumothorax. A lot is written about being able to identify neonatal cardiac diseases based on x-rays, but honestly, this is not very sensitive. Like I've said a few times, what can be most helpful when getting an x-ray and you're trying to figure out whether there's a cardiac disease or not is to see how much blood flow there is to the lungs. Is it really black and there's not a lot of blood flow going, or is it really white and there's loads of blood going to the lungs? But it's still important for you to understand where the borders of the heart are. So here you can see that the right side borders of the heart are kind of the right atrium at the top, the right ventricle at the bottom, and then the left-sided border of the heart is the left atrium and the left ventricle right there. And the pulmonary vessels are the ones that we should be able to see very easily going into the lungs. Okay, and then moving on to the letter D, we're looking for disabilities, especially fractures. Look at the clavicles where there are very commonly areas of fractures right here, the clavicles or the collarbones. And then look down towards the ribs. There should be 12 ribs, but some babies have 11. Often this can be associated with a genetic disorder like Down syndrome, but it's approximated that about 5% of all people have 11 pairs of ribs. Obviously, we can't count the ribs all the way down unless we also have a KUB. Also, get used to how white the bones look. Obviously, this is going to depend on the exposure, but generally, if the bones are like really super pale, then you are worried that the baby could have some level of osteopenia. Also, get used to checking the vertebrae. Are they rectangular and similar heights? Sometimes the vertebrae are made abnormally. So for example, you could have a butterfly vertebra, which literally looks like kind of like a little butterfly. This can be associated with some genetic issues as well. And then moving on to E, looking at everything else. Look for unusual areas of gas, whether it's under the diaphragm, in the pleural space, maybe even in the liver. Check all the positions of lines and tubes, or whether there are any surgical clips present or anything else unusual. Obviously there aren't any here, but make a point to look at all of these. Okay, let's put all of this together. So this is another chest x-ray that you just got in the unit. So let's look at the quality of the x-ray first of all. So it doesn't seem too white or too black, so it's not too over or under exposed. You can see that there is some nice air in the gas bubble there. There aren't really any artifacts covering the baby, so no lines or little temp probes or anything on the baby that may be getting in the way. And what about the rotation? The ribs seem like pretty similar lengths on both sides, so it's not really rotated. Now let's run through the A, B, C, D, E. So A, the airway looks nice and straight and midline, and you can see the carina nicely there. The lungs are symmetrical, and let's count the ribs. 1, 2, 3, 4, 5, 6, 7, 8. So nicely expanded ribs. They're both quite dark on both sides, with no areas of obvious collapse or infiltrate, no areas of like kind of whitish collapse or consolidation or anything. The heart border looks good. It's mostly on the left side, which is what we'd expect. And we have good pulmonary vasculature. So you can see all these little vessels go all the way out to the edges of the lungs. So obviously less concerned again about a pneumothorax. There seems to be no obvious bony abnormalities with the ribs. The vertebrae all look very nice. The clavicles look nice. And nothing else crazy is going on. Nothing in the chest or weird tubes going in the wrong places. So altogether, this is a normal, lovely x-ray. Get used to knowing what a normal x-ray is like, so you'll have an easier time spotting an abnormal one. And that's the end of our introductory session. Make sure to go on and see all the other videos that we're making with the abnormal x-ray findings in them. And if you like this video, please like it on YouTube and subscribe if you want more neonatal content. Thanks so much for being here.